So my name is Dr. Nesset. I'm a respirologist. I'm doing an additional fellowship here at McMaster at the Firestone Institute with Drs. Kolb and Dr. Cox and Dr. Scallan and Dr. Hambly. And that's been made entirely possible for me by the Robert Davidson Fellowship from the CPFF. So that's something I was able to begin my fellowship starting in September. And I'm very excited to sort of share with you guys what that's looked like in terms of the research progress that we're making and activities that I have planned for the future in terms of presenting that research, and then my future sort of career set up in Kingston at Queen's. I'll be joining their specialist team there to become a permanent ILD physician in the region. So again, I'm sort of delighted to be able to meet everybody and kind of update you all. So I started my fellowship as primarily a research fellowship, and so my area of interest is looking at how frailty, which is a measurement we can use in patients with ILD, how that might affect what patients want or how they interact with the care we provide. And my main goal is to determine whether, if we actually measure frailty in clinic, does that help us make decisions about those patients as to, treatments that might be helpful for them, or primarily things that might help them feel better. So if a patient presents with more frailty, are they someone who would benefit from, more virtual visits so they can stay at home and not lugging in their oxygen tanks and all of that? Are they someone who would benefit from referral to a specialist in symptom management earlier? Is that something that they would benefit from? So I'm really interested in how those measurements interact, how we can improve the lives of those patients. And we have a wonderful study called the Connect ILD study happening here at McMaster. And that's an ongoing data collection. So we have 150 patients enrolled in that study, and they are using home monitoring devices. So they're able to monitor their disease from home. And one of the things that I've been able to do is kind of go through and measure their frailty status, which is something we have in the literature. We use a specific scale for that. To answer your question, Dr. Smith, we use the clinical frailty scale, which is it's a pictograph scale. So you can look at pictures and they've got sort of prompts, and you can stratify people according to not frail at all to very frail. And so using that, we can sort of stratify them into the levels. And I'm looking at how they interact with our monitoring system, whether, patients who are more frail are less likely to use it or to enroll in the study, whether they're more likely to benefit from it in terms of the education things we provide and what that interaction looks like. So we have some preliminary data for that that's just getting started now that we have people enrolled. We're kind of following them over months. But I'll be able to, I've just been accepted to present that data at the American Thoracic Society conference in San Diego in May. I'm excited to bring it. I think it'll be a very interesting, perhaps a change in perspective in how we look at frailty. So previously, when we talk about frailty, it's been used to sort of decide, okay, how well are people going to do on our treatments? Will they live longer, or will they live less long? I'm excited to open the conversation about how that measurement can help us better address their concerns, not so much our treatment concerns, but actual patients, and what their preferences would be just in that context. Because there certainly are sort of more vulnerable patients, are more frail patients. At present, the data we're looking at is looking at the frailty status right when they enroll in the study. So starting out, where were they? One of the things we look at when the data closes is, okay, redo my assessment and say, has that changed? This study won't have the power to say whether, our interventions changed it, but it'll be an observation of whether or not that's a trend or something we want to pursue and further research from there. And I think sort of having a chance to look at this population from that frailty lens can help us find those patients that might benefit, the most from things like palliative care, even if intermittently, and then they feel better and they don't need that same follow-up, or better managing their symptoms. So that's something we're looking forward to. And the study itself has had really good preliminary data. We've had great enrollment. The initial satisfaction scores from patients have been really, really high. We've actually received some really lovely positive comments about the physicians in the group here that we were able to kind of share and put forward, which certainly helps motivate us from that end as well to continue on that work. So the data collection for the Connect ILD study involves very much online data as well as home spirometers. So they measure their lung function at home weekly, and they measure their oxygen at home weekly. So they're given a home oximeter and a home spirometer to use on a weekly basis. And then there's an app that's available, and patients do daily check-ins on the app through the Seamless is the company that created it. And so the Seamless group collects all of that data as to their daily symptom profile. They collect data as to how often they log in, what patient education resources they're accessing. And then every week we have the spirometry and the oxygen measurements, and every month they actually fill out some questionnaires for us through the app about their quality of life, their symptoms, and their satisfaction with the monitoring as well. From my end on the frailty side, that's very much an electronic chart review. So I go through the notes from physicians that are available to us on our EMR, and I go through, and using that scale and the information that we collect, I make a score. I assign them their score based on that. And that's something that's been done at McMaster previously in our ICU patients, and it's found very, very valid in terms of it's the same almost as when you talk to family members and occupational therapists and all of that. So it's been helpful to have that available to us. So I'll tell you, there's sort of two things. Connect ILD is looking at the feasibility of a remote monitoring system in all patients with interstitial lung disease. Awesome. That's whether that's something, that's why we're collecting all of these metrics. Does it improve their quality of life? Does it improve, our ability to catch changes with that home spirometry in their lung function before we'd see them in clinic? And can we act on that? And then do they actually appreciate it, or do they find it annoying, or do they rather we worry about X, Y, Z? So that's sort of the feasibility side of it from their study. And then my study individually, which is very kindly made possible through you, is that frailty component of it. So how does that more frail population interact with this? And is it something that we need to be thinking about when we implement sort of system-wide things in ILD? So the preliminary data that I've had a chance to look at, so I looked at 30 patients, and we weren't able to look at their home spirometry and oximetry. There just wasn't enough data to do anything meaningful with that. But what we found was that patients who were found to be frail are about the same prevalence in the study as they are in our general population. So patients who are frail are not less likely to be part of our study. They're not less likely to engage with this technology. They're about the same likelihood as anyone else. And then there was no significant difference in what we saw in terms of their satisfaction or their quality of life scores or their interaction, how many times they used it, how many times they interacted with the education things compared to the other population. Now, it's a very small sort of subset of our group, but essentially the takeaway I think from that initially is that, frailty does seem to be a feasible option, or at least remote monitoring in patients with frailty is a feasible option. We were a bit worried that they wouldn't engage or they'd engage less, and that doesn't seem to be the case. So that's been promising. Frailty is being defined by the clinical frailty scale. So that came out of Canada, actually. And it came out of a study, a really large study in older adults. So in any adults over 65. And essentially what it separates is it's a 9-point scale. So from 1 to 3, you'd have very fit to managing well. And then from 4, you'd say they have mild frailty, 4 and 5, and then 6 and 7 and 8 are severe or moderate to severe frailty. So it just kind of depends. And it takes into account a whole host of things. It takes into account how active they are. It takes into account, if they depend on other people to help them with things like showering, bathing, getting dressed, those items. And so it's a bit of a holistic assessment of how well they're doing, and they stratify into those categories. So the data is all available. So all of our electronic data is available through the Seamless MD web platform. So the Seamless company, we meet with them every 2 weeks actually to go through recruitment and the data and making sure that it's delivered to us in a way that's useful. And so Seamless collects all of their spirometry data, their health questionnaires, their satisfaction scores, all of that, and then they send us that data for analysis. And then in terms of assigning frailty, that's something that I do on chart reviews. That's something that I have and measure. You know, I'm at the very early stages of my career as an ILD physician, and I want to build on this over time. So in my ideal world, eventually we measure frailty, and let's say someone goes from being mildly frail to very frail. We say, okay, so now in this patient, we know that, you know, it's time to go to a pulmonary rehab program and see if that, you know, knowing that that might make things better. It's time to go to symptom management earlier rather than later so that they can keep up their strength and not get too breathless and get weaker. So the way I see it is building a care model around that so that we can have those interventions earlier than we do them now. Research shows that now we tend to wait a long time before doing those things. Well, I think this provides, you know, especially with Seamless, what their patient education bit provides, and I haven't sort of delved into that too much, is it often gives sort of preliminary answers to questions that patients commonly have. I'm having an increased cough. When should I worry? I'm feeling a bit more short of breath when I exercise. What can I do to help with that? And it has those initial sort of strategies or information that they can use. And in the satisfaction surveys, the initial ones, patients have really appreciated that. I think it provides a bit of a sense of ownership as well. They feel more in control, right? And I think that's really important, that they have that ability to be in control and to know, you know, the other piece of that is it tells you when to seek help and to just have that reassurance available at any time, whereas, you know, physicians, we can't always be. And I think that's something I'm really interested in as well, you know, from that idea of patient-reported outcomes and what makes our patients feel better, what's most important to them, and make sure that we're addressing that in the research that we're doing as well.